Good morning. I hope you all are have had a chance to sleep in, are well rested from Thanksgiving, and are enjoying your day off. Or get out there and go throw some snowballs, go sled riding, think about the movements you're doing while you're doing it, or just have a little fun. Um, I'm gonna talk a little bit about neck and trunk as well as TMJ, just so you have all this information as we're going through. Please jot down any questions you have, and when we come back together, we'll make sure we answer them. So, in the neck and trunk, just as a reminder, we have our four spinal curves, which help create stability as well as strength in the spinal column. If everything was just stacked directly one on top of one another, we'd be more prone to injuries. The spinal column itself would not be nearly as strong. So we have our cervical and lumbar lordosis and thoracic and sacral kyphosis, which is our normal curvatures. At the neck and trunk, we have flexion, extension, hyperextension. We also have lateral bending, which you will also see as side flexion or side bending. All of those are correct. And then we also have rotation. We talk a little bit about axial extension in the neck, not the trunk as much, but axial extension, when we talk about the neck, if you do a chin tuck, you are technically flexing at your neck, but you're also extending your cervical spine. And so doing a chin tuck is that example of axial extension, which is a slightly different movement because we're actually doing several different things at the cervical spine at different levels. So you would be flexing at C1, C2, and extending through the rest. The next couple slides look at your bony landmarks of the skull and the vertebra. I know that we're stuck home in lab on Thursday. We're going to kind of do a mashup of trying to sort of put everything in as much as possible, just so that we have this information. And so just take some time and review these bony landmarks as they are relevant to the different areas of the body that we're talking about. So just some additional pictures. You should see these on your notes. Just make sure you understand where these are. Remember that our C1 and C2 are going to be different shapes than the rest of the vertebra, significantly different. Our C1 is going to have this circular shape. We call this the atlas is going to be our C1 and the joint between the occipital bone. And C1 is atlanto-occipital joint. And so you can see here, posterior and anterior really kind of look similar. We do have the transverse process, but we do not have a spinous process. This is going to be C2 or axis. Axis is going to have that superior protrusion of the odontoid process, or we simply call the dens. We have a transverse process. We have a spinous process, but still slightly different shape than the other vertebra. This looks at your cervical, and then the middle there is thoracic, and the bottom is the lumbar vertebra. And you can see how the shapes change, as well as that vertebral body significantly increases in size. And this is going to really help with load distribution and accepting forces, especially ground reaction forces. We need those really strong bones at the bottom of our spine. I don't know about you, but when I look at these different levels of the spine, I actually see different sort of um, animals, and that's how if there's just happens to be like a random um, spinal level vertebra length, in the lab, I can usually pick it up and tell what it is because to me it looks like an animal. And so when I look at cervical spine, because of sort of that split spinous process, to me the cervical spine looks like an anteater. The thoracic spine to me looks like a giraffe, and lumbar looks like a moose. And so if that helps you, great. If not, um, Some things to note when you look at these, not only is the body going to change in size, but our facets, so where we are articulating, um, with the level above and the level below, are going to change orientation. And so some facet joints are going to be more up and down versus some are going to be more at an angle. And that change is going to change the amount of movement that's available. So, for example, if you look at the if you take a spine in class and you look at the different vertebral level and you look at a cervical vertebra, you're going to have your facet joints basically straight up and down. Or I'm sorry, they're going to be on an angle. And when they're on an angle like that, that allows for things like rotation and side bending with flexion and extension. Versus at the thoracic area, those facet joints are going to be pretty straight up and down, which are going to really limit a lot of your mobility. We have some other things in the cervical spine that are going to limit mobility as well. So, looking at the different joints, again, our joint between our atlas and our occiput is going to be the atlanto-occipital joint. The atlas superiorly is going to be concave, whereas the occipital condyles on their inferior point are going to be convex. It is a synovial joint, so it comes with a synovial membrane, synovial fluid, all of the different things that we expect to see with that. We have flexion and extension as well as side bending with rotation to the contralateral side occurring at this joint. You can see here the orthokinematics are going to be labeled, and this is going to be based off a traditional convex concave rule. So knowing what part of the body is moving is going to help you with this. Moving down one level between C1 and C2, this is the AA joint, the atlantoaxial joint. This joint has three different joints that make up the total connection between C1 and C2. And so our more medial joint is going to be the articulation between the dens or the odontoid process of C2 with the anterior arch of C1, again synovial. This joint is going to be surrounded on by the anterior and posterior AA ligaments, which we'll talk about in a little bit, and that helps hold that dens in place. And that allows us to rotate around it. So we have spin occurring at that joint. Out laterally, we have two joints with the inferior articular process of the atlas as well as the superior articular process of the axis. And these are also synovial joints that allow some flexion and extension. Now, they don't allow a lot of flexion and extension because that dens comes up and hooks onto C1, but also because of those anterior and posterior ligaments around the dens, it really helps hold the dens to C1, which provides really necessary stability. As you can imagine when you're thinking about the brain transitioning into the brainstem. As the brainstem exits the bottom of the spine or the bottom of the foramen magnum, there it becomes the spinal cord that is running through this area. So we need to make sure we have really good protection. And so if that dens was able to really move away from C1 or C2, we would be putting too much pressure on the spinal cord, causing unfortunately, it wouldn't just be a spinal cord injury, it would cause death. Again, we have facet joints, which are going to be articulations between the levels. We typically call them facet joints. You may also hear zygoapophyseal joints. That's the technical name for these areas. This is going to be the articular process, the superior articular process from the vertebral level that is lower, with the inferior articular process of the vertebra that is higher, and this goes from C1 or C2, sorry, to S1. S1 to S5 are fused, so they do not have facet joints in this manner. Again, they are synovial joints with a capsule. In the cervical area, we have all four motions. Whereas in our thoracic area, we have side bending and rotation again because we have that more straight up and down frontal plane rotation. And then lumbar, we get more flexion and extension. We have a sagittal plane orientation of these facet joints. The closed pack position for all areas is going to be maximal extension. They're going to lock those bones against one another. In the thoracic area, we also have another joint, the costovertebral joints. Um, and this is going to be where our ribs come in and articulate with the spinal levels in the thoracic spine. And we have a couple of different areas, two different areas that the rib is going to articulate with. So the first is the demifacet, and they're called demifacets because each rib articulates with half of a facet on the vertebra above and the vertebra below. So one rib to two vertebra. We also have the costotransverse joint, where the rib is going to articulate at its tubercle to the transverse process. And so here's a picture where you can see those different articulations. And so we have that costotransverse, more superior lateral, and then our demifacet closer to the body. Here we can see our different ligaments of the spinal area. And so we have the anterior and posterior longitudinal ligaments. So if you look at that top picture there, your anterior ligament is going to be on the anterior portion of the body, which is actually deep to like get the inside of your body. And it's going to run along the vertebral bodies, whereas that posterior longitudinal ligament is going to live posteriorly to the body, closer to the spinal cord. Our supraspinal ligament, you can see also in that top picture there, your supraspinal ligament is going to attach your spinous processes. Your supraspinal ligament is going to be important in preventing excessive flexion. As you flex and those spinous processes move further away from one another, that's going to help stop that motion. Your inner spinal ligament is going to run from level to level. So we talk about it as one ligament, but really there's a ligament between each vertebral level. So it's going to connect the underside of the spinous process above to the top of the spinous process below. Again, limiting that flexion. The nuchal ligament is going to be in place of the supraspinal ligament in the cervical spine. So it's coming off the occipital bone down to the end of the cervical spine. So we don't have supraspinal ligament in the cervical area with the nuchal ligament. And then our ligamentum flavum, you can see in either picture really there, the ligamentum flavum is running and anterior to the spinous process, but within the spinal cord canal itself. So it's going to be more posterior to the posterior longitudinal ligament. Again, very important for keeping that stability so that we don't have pressure and unwanted movement occurring on the spinal cord itself. As I'm sure you've talked about in probably thorax at least, we have the intervertebral discs that live between each level of the spinous vertebra in the spine. And so outside concentric rings of fibrocartilage, increasing the stability in the annulus fibrosus. Inside is that jelly-like material, the nucleus pulposus. We see this starting at C2, between C2 and C3, and then running down between the last one between L5, S1. We have those little models that I think you guys were playing with whenever you were talking about exercises and thorax to think about how the vertebral disc moves when we add motion, so flexion, extension, and rotation. If you've not played with this, make sure you do so. And when you're thinking about things like herniated disc, which I'm sure you may have talked a little bit about, think about where all of the ligaments we just talked about are located, as well as how that disc moves. And so if we go back and we think about this, we have no ligaments supporting and no strong muscles in the area of where we commonly see disc herniations especially in the lumbar spine. And so that's why we see them posterior lateral. Moving to the muscles, we're going to separate the muscles into neck muscles then into trunk muscles. And we can talk about our cervical muscles as being anterior um, and then posterior. So as we go through these here, sternocleidomastoid, SCM, originates on the sternum and the clavicle, and it runs up to the mastoid process. So it's kind of this triangular shaped muscle with a diagonal line of pull. If both sides of the sternocleidomastoid are working together, we're going to get neck flexion. We can also get hyperextension in the neck. And the reason why this happens is because once we tip past a neutral, the diagonal line of pull is such that we can actually then pull back into um, an extended position. Unilaterally, it's going to laterally bend the neck and rotate the face to the opposite side. It is spinal accessory nerve, which is cranial nerve 11. So it's one of the only cranial nerves that innervates muscles outside of the head itself. And it also gets innervation off of the second and third spinal nerve roots in the cervical area. And here you can see sternocleidomastoid. Our next muscles are our scalene muscles. We consider these anterior muscles, but they also do come pretty laterally. So we're going to think of them as one muscle. They're one muscle group, but they're three different muscles. But we talk about them as one because of their action moving together. Excuse me. So they're going to originate off the transverse process of the cervical vertebra, and then they're going to go out to the first and second ribs. Bilaterally, they help with neck flexion, and it's assisting at best because they are so lateral. But unilaterally, they're going to do side bending to the side that you're using, and it is lower cervical nerves provide innervation. So here again, you can appreciate how laterally they are. Let's make sure you don't get too far posterior that you're going onto the levator, scap, and upper trap. So this is going to be anterior scalene, middle scalene, and then posterior scalene. Looking at the muscles in the posterior, we have the longus colli, which is going to be that more medial muscle that you see here. It's coming off the bodies in transverse process C3 through T2 out to the transverse processes and bodies, or I'm sorry, up to the transverse processes and bodies of C1 and C6 through C6. This is going to help flex the neck, even though they are located more posteriorly, as well as perform that chin tuck or that axial extension. They're anterior primary rami of C2 through 6. Moving out, this muscle is going to be that darker orangey colored muscle here, longus capitis. This is transverse process of C3 through 6, runs up to the occipital bone. Again, flexing the neck, performing that chin tuck, and it's using branches of the cervical plexus are going to innervate this muscle. Rectus capitis anterior, super tiny little muscle coming from C1 up to the occipital bone. So it's going to flex the head and help with a chin tuck, but only as the head moves on C1. It's getting innervation from spinal nerve roots C1 through 2. Rectus capitis lateralis is that most lateral muscle. Again, not a very big muscle. Transverse process of C1 up to the occipital bone, and it's going to laterally bend out the head on C1. The innervation is coming from the ventral primary rami, the first nerve root. Then looking at the suboccipital muscles, these are located just below your occipital protuberance. These are super important to understand as a group because we have so many people that have increased tension of the suboccipital muscles. And a lot of that is due to the common posture that we see because of electronics and the way we sit these days, where we have this sort of hunched over back with our head in a extended position puts a lot of excess or excessive tension on these. So performing a suboccipital release, it can be very helpful for these muscles. And so we just need to know that they are posterior below the occipital protuberance. And we have obliquus capitis superior and inferior, rectus capitis posterior minor, rectus capitis posterior major, and they are going to perform extension as a whole. The two that have the star also perform lateral bending and rotation to the same side because of their the way the diagonal line of pull there. And so you can see the suboccipital muscles. And important to note, and I think this picture does show nicely, is that you have them on both sides of the spine, just like these other muscles that we're talking about. Um, More superficial posteriorly, we have the splenius capitis. So coming off the nuchal ligament and spinous process of C7 through T1 up to the lateral occipital bone, as well as the mastoid process. When both sides are working together, we're going to extend the head and neck. But when only one side is working, we're going to rotate and laterally bend to the same side. And this is middle and lower cervical nerves. Here you can see that splenius capitis. Then we have splenius cervicis. This is going to be spinous process T3 through 6 up to the transverse process of C1 through 3. Similarly, they're going to extend the neck when working bilaterally. Unilaterally is going to rotate and side bend to the same side. And it is middle and lower cervical nerves providing innervation. As we move down into the trunk, we're going to talk about our anterior surface muscles. So our rectus abdominis is going to be that muscle that everybody covets. They want that 6 or 8 pack. And this comes off our pubis, goes up to the xiphoid and the costal cartilages 5 through 7. It does help with trunk flexion. It does help some with compression of the abdomen. And while we all really would like a rectus abdominis, it's not providing significant support to the core. It just helps give you a flatter stomach. So 7th through 12th intercostal nerves. And you have one on each side. It's connecting by the linea alba that runs down the middle, which means white line, and it's just a fibrous tissue. So there you can see. You can also see that the rectus abdominis has 6 fibrous bands that run horizontally across it. 8. That's what causes the definition that we see in some individuals. Moving out to our obliques, our external oblique is going to come off the lower 8 ribs laterally to the iliac crest and linea alba. Bilaterally, it's going to compress the abdomen. It's going to flex the trunk. Unilaterally is going to laterally bend and rotate to the opposite side. So external is rotating to the opposite side. You can see there in the picture that when you look at the external obliques anteriorly, Their muscle fibers, if you're looking at both sides, create a V because of the way they're running. They have a connection again on that linea elbow that helps create that really long connection in the middle. And it's 8 through 12. Intercostal, iliohypogastric, and ilioinguinal nerves. And here you can see that external oblique. The internal oblique is going to be in a similar area. However, instead of having a V appearance whenever you're looking at it on both sides, it's going to be an inverted V. So inguinal ligament, iliac crest, thoracolumbar fascia. Inserts on ribs 10 through 12, as well as the abdominal aponeurosis, which is also the linea alba, another name for it. Compression and flexion when used both sides. And then it's going to be different from the external oblique in that it does lateral bending and rotation to the same side. So internal oblique turns into the same side. 8 through 12, intercostal, ilio, hypogastric, and ilioinguinal nerves. And there you can see that internal oblique. So just different fiber arrangement causing that rotation towards or away from, depending on the oblique you're talking about. Moving into a really important abdominal muscle that gets overlooked, our transverse abdominis. Our transverse abdominis is super important for maintaining that good strong core. Originates off the inguinal ligament in the hip area, iliac crest, thoracolumbar fascia to the last 6 ribs, up to the abdominal aponeurosis and linea alba. Compression of the abdomen. So it's not actively flexing the trunk, but it's providing that compression, that stability and support of our core so that all of our other muscles can work most efficiently. 7th through 12th intercostal, iliohypogastric, and ilioinguinal nerves. And there you can see that transversus abdominis. Transverse abdominis, transversus abdominis, you'll hear it both ways. Posteriorly, we have a couple muscles that we're going to be talking about. The main one is going to be the erector spinae muscle group. The erector spinae are a group of muscles made up of the iliocostalis, longissimus, and spinalis. And so, again, functionally, they all work together. So we're going to kind of think of them as one. So they're coming off of spinous process, transverse process, posterior ribs, occiput to sacrum and ilium, and inserts on the same areas. Each muscle has a separate origin and insertion. We don't need to know it for this class. We're going to cause extension of the trunk and neck when working on both sides. Unilaterally, it's going to laterally bend the trunk and neck to the side that is working, and it has various spinal nerves. And you can see as we look at the pictures of these muscles that it creates sort of if you look on either side of the spine, the muscles that sort of create like a big mound that run together. This is our rector spinae. And so we're starting more laterally, moving medially towards the spine, but really functionally, they're all doing the same thing and they're grouped together. We also have the transversospinalis groups. This is also a group of muscles made up of the semispinalis, the rotators, and the multifidi or multifidus. They're coming off of the spinous process, transverse process, inserting on the spinous process above. And how they insert is how you can differentiate which one is doing what. So, for example, your rotators are going to originate on the transverse process, go up one level to the spinous process, versus your semispinalis is going to start on a transverse process and go up at least 5, if not more, vertebra to the spinous process. Your multifidi, it'll start on the transverse process and it will only go 2, 3, or 4 vertebra above. And so the longer the muscle, the slightly different group it is, or different name it is. Bilaterally, they extend the neck and trunk. Unilaterally, they're going to rotate to the opposite side, and it is spinal nerves. So here you can see again if they're, depends on how far they're spanning. Interspinalis are going to just go from tip of the spinous process below to the tip of the spinous process above. So a series of short muscles that are all the same, but just stop and start at each spinous process. They're going to cause extension, and they have various spinal nerve innervations at each level. The transversi are going to originate and insert on the transverse process. So it starts below, runs up higher, and it's going to cause lateral bending when working unilaterally to the side that is working. And then quadratus lumborum is a deep muscle sort of above your iliac crest. It originates on the iliac crest and runs up to the 12th rib, transverse processes of all 5 lumbar vertebrae. It's going to do trunk lateral bending, but it's also really important in performing a hip hike. So in order to lift your hip up and standing, you're going to use a reversal of muscle action. And it is 12th thoracic and first lumbar nerves are innervating it. And so there you can see it. That one looks pretty posteriorly. When we're palpating it, what we're going to do is go off. We're going to have our hands on the iliac crest and push in and then feel for it there. I have a list here of common vertebral column pathologies for you. Make sure you review these and you're somewhat familiar with them. Let me know if you have any questions about this material.